with regards to the agenda today, we've got several items on the agenda that I think will be quite useful to many of us. The first item on the agenda, if we can just put the agenda up. So the first item on the agenda is Paul, one of our directors at NHC, that's going to be going through some notices for us. So I'll just hand over to you, Paul.
Thank you, Arpana. Hello, everyone. Hi there. I've only got two notices to go through. One is details about our AGM, and the second is just some information about RSV, and I'll hand over to Asma in a second. Just as a quick early heads up and a save the date request, the NHC AGM will be held on the 17th of October in the evening, 6 till 9 p.m. We've got the gantry booked in Stratford, and details will be sent out shortly to all our members and across primary care in Newham. So that's the first notice, and then the second one is regarding RSV and asthma. Would you like just to
Yes, hi everyone. I'm Asma Karim from NHC. So RSV virus. So for the vaccination for the pregnant women, the toolkit and the guideline has been published through our ICB colleagues widely. So we are just after this meeting, we will share that to all of our practices. So I'm just bringing a verbal awareness here that please look into that and take appropriate action to vaccinate your pregnant women and protect the children from this respiratory virus. Thank you. That's all from me.
Brilliant. Thank you, Asma. So that's the notices from myself and from NHC. Arpana, would you like me to hand over to the Danielle for LMC update?
Just before that, can I just add a few things with regards to the RSV vaccination? So I think the variation in terms of the practices actually starting administration is due to various factors. So one of them is fridge space. So I think we've all, many of us have got our flu vaccine deliveries this week. And one of the issues is that we're not able to start vaccinating all of the cohorts just yet. So our fridges are full of the flu vaccines. The RSV vaccine box is larger than your average vaccine box. So I think that what I would, just a recommendation from my side and having spoken to other GP colleagues, is that if we request small amounts of the RSV vaccine, but do start giving it, because the weather is really variable at the moment. But I think before we know it, it's going to start to deteriorate and the virus will increase. So we need to start it sooner rather than later. And in terms of if there is anything that practices feel that NHC can help support them with regards to administration of the vaccine, please do contact us and we'll look into see what support we can offer.
Much, Arpana. I think this is very useful, and that was probably the main reason to bring it here. Thank you.
Right. So first up on the agenda, we've got our LMC team. So we've got Tammy, and then we've got Daniel with us. So I'll just hand over to the two of you.
Hi, everybody. I don't know if Tammy is on the call yet. So I'm Daniele Serra. So I just wanted to introduce myself because I'm new. This is my second week. I'm the new Assistant Director of Primary Care, and I will be working in Northeast London. So I'm really looking forward to working with all of you. So as I said, my second week, so I'm still getting my bearings, but there are a couple of things that I wanted to update you on. Firstly, one of the key area of work that I will be focusing on is the review of the enhanced services, the leases. We met with the ICB last week for a bit of a reset and restart of a program of work around this, and we're going to be holding our first contract meeting next next week. I believe it's on the 19th. I've met the new head of primary care for the ICB for Newham, who's Jack, and I think he's on the call as well. And we kind of agreed a process for the review meetings, and we will be developing a work plan around it. So we will obviously give you further updates as the program develops. The other couple of things that I wanted to update you on. I mean, obviously, I have to mention the letter that you will all have received around the SMS text messaging cap. So obviously, as an LMC, we have reiterated to the ICB that our opposition to this decision, and we can't support it. However, I understand that it's mainly linked to the ICB financial situation at the moment. And I suppose the only positive thing is that they have not cut the budget. They've kept the budget at the at last year's level, which is a small win. However, it is unsatisfactory because if practices go above their allocation, they will be charged, and we have been very clear that as an LMC we cannot support that. So we will keep having these conversations with the with the ICB, and I believe that they will be contacting the 50 top users practices in North East London to sort of look at the data, and presumably they will work with the practices to see how best to optimize the use of the text messages. We've also been having discussions around an evaluation of advice and refer, and we've been heavily involved in devising a scoping document and a bit of a specification of what the evaluation will entail in terms of assessing what the impact of the service is, and this was obviously inform the next steps on how we take forward advice and refer in North East London. But again, what we've reiterated to the ICB is that as an LNC, we want to be engaged in this evaluation to make sure that the GP voices and the GP input is taken into account. And then finally, the final thing I wanted to mention is the work that is going on. You might know that the ICB will be reprocuring the NHS 111 service in North East London. So we met with the leads in the ICB this week to get an update, and it's still very early days. There still isn't a finalized model for it. It's still a very high level. Sort of, there are some options that they're considering, but not much meat on the bone. And of course, again, we've reiterated that as an LMC, we wish to be involved in those discussions, and any impact of any changes in the service, any impact on general practice, we need to be there to sort of assess it and making sure that they're taken into consideration. So that's my quick update from us. I don't know if Tammy has joined and if she's got anything else to add. Thank you.
Hi, Daniele. Sorry, I got a bit caught up with a group consultation.
Don't worry.
So apologies for being late. What have we covered? Did you give them a little bit of an update, Daniele?
Yeah, so we covered the discussion we've been having on the enhanced services review with the ICB, the SMS text messaging, advice and refer, and NHS 111.
Perfect, thanks. So I suppose the only last thing, I don't know if Lara is on the call, is just, those ongoing conversations about the collective action that everyone's concerned about, and just being really clear that obviously in our LMC role, we are not here to advise you what to do. We are really here to facilitate conversations. And I'm hopeful that our NHC colleagues will be able to maybe support us in having further conversations at their AGM. I'm putting them on the spot a little bit. I know that has to go to board, but it'd be really nice if, I'm hearing the concerns around this, and it doesn't mean that we have to, as Newham, do the same thing every day. day, and every practice or every PCN do exactly the same thing every day. The whole point is that they are 10 collective actions. You choose from those, but they are the 10 actions that across England that GP surgeries will be following. So just be really clear that this is just the advice from the BMA, and if anyone was listening to Radio 4 this morning, Katie was interviewing really well, and you can always listen to it on BBC Sounds. It's about 7:35 this morning if you want to go and have a listen to that soundbite. But if there aren't any questions, and Danielle, thank you for stepping in while I was busy. But yeah, we're open to those now. Yeah, hi Wax.
Hi Tommy. So have we had any thoughts about how we're going to get in touch with patients to complete our SNSs and our enhanced services and QOF without text capability, or the threat of being charged if we go over the cap, or until April, the threat of being contacted by ICB around texting out? We still got a lot of SNS work and QOF work to do. So there's one thing about someone at some point negotiating some resource to continue the funding for the texting, but there's also solutions that we need help with. Has anything come from the ICB around that, more than what's been put in the sort of emails around being mindful of texts?
So sometimes I find those things really hard to answer, because I think that isn't within our remit. That's really probably for Jack and the rest of the ICB to maybe answer. However, I think from our perspective at LMC, and I'm sure Danielle has pointed this out, is that actually we were really clear from the inception of this sort of initiative that it wasn't going to work for us as practices. We thought it was a retrograde step. We're very aware that our patients need several reminders. They don't attend appointments, and actually it's not really cost effective in the long term if they're missing appointments because we haven't got the ability to remind them. And also we can't support our secondary care colleagues either if sometimes we know there's a patient who misses appointments and actually needs that reminder. So it doesn't support that sort of collaborative working. It doesn't support the information that we need to give our patients, so for informed consent, all the information that we give with care plans. So I absolutely agree with you, but I think as far as Kate and the rest of the team are concerned, we will continue to highlight that this is a problem, and what we do need from you as practices are those examples. So if you're finding that actually you need to send out a message for patients, and it's basically a health inequality, isn't it, if they don't have that sort of additional support, we're taking it away, that we need to make that business case, and only you as practices can give us that information to take to the ICB. So back at you in a sense about making sure that we do have that information, because we need them to appreciate that it isn't appropriate for practices.
I mean, my position is quite clear, and we don't work in Portsmouth or in the Shires, and when we text people to come and get their flu jab, we have to do that. We don't have that kind of lack of hesitancy. I'm using flu as an example, where program starts October 3rd, everybody comes on one Saturday, and everybody in the footprint of that borough in the Shire is vaccinated. We have to go out, we have to text, we have to call recall. And the problem that's going to happen is that where we were saving a lot of time with self-booking in terms of picking up the phone and calling patients, we're going to be wasting a lot of time. I can't see how we're going to complete our enhanced services and cough work with picking up the phone. And of course, the phone's not cheap either anymore either. So we're kind of on a note. I think if whoever's having those discussions from the LMC kind of perspective and we're doing it from the primary care lead kind of perspective, saying that, you know, if there's a bit more guidance on how to be mindful around text, alongside that ongoing negotiation about increasing the resource. On the point about enhanced services, Danielle, I think it'd be good to know who'd be involved in those conversations with the likes of Jack, Pat, Will, etc., and whoever else is involved with the ICB. Reason being is because you know, we've talked a lot at United Voice and LMC meetings and various forums around how actually we've lost X amount of pounds per patient because a different way of commissioning and contracting enhanced services work. That's one way. Some services has been retired, etc., and stuff like that. And actually, other services that we're offering the right things for our patients. So it'd be useful to know who'd be involved in those discussions from an LMC perspective. One, to stop avoid duplication, and two, to have that one strong voice from sort of primary care, clinical kind of ICB kind of situation, but also LMC, PCN, CD kind of situation as well. Absolutely conscious that, you know, we don't even know fully what our enhanced services are for the year and stuff like that. And there's always a bit of a delay, there's a bit of a lag and stuff like that. But we need to be united when we're working with Jack to solve this, but also find and understand and have materialized what resource there is available to increase that portfolio of funding. It's good to know who's involved in those discussions.
Absolutely. Thank you. And I think you're absolutely right. I mean, the first step that we've been doing this week is to start and doing a bit of you know, where are we with all the enhanced services? You know, which one have been agreed, which one are still in draft, etc. So I think it's, that will be the first step. I mean, certainly for myself, because I need to get my head around all the specs. But yeah, we can provide you guys with who's going to be involved in all the review. I think obviously Jack will be, I think he's on the call. I'm not sure who from his team will be involved, but I'm sure he will be involved. And then from the NHC, there will be me, Shabnam, and I'm sure there'll be other people involved. So we can let you know who in the team will be part of the working group.
Okay, thanks, Daniel. So we've got Laura and then Anil. And just to remind everybody, if you have any other questions or comments, put them in the chat bar. And this meeting is recorded as well. Okay, Laura?
Good. Hiya. Yeah, just from the digital point of view, from my role there, and by the way, don't shoot the messenger. I know how bad this is for everyone in terms of the text messages. So this isn't to sort of say everyone will be okay, because I do totally get what everyone's saying about the impact it's going to have on loads of different levels. But just to say that there was advice in the letter that went out, and there is going to be further advice on webinars about how to use the NHS app to try and help some of these messages. Now, obviously, remember, this is just for the batch messages, and it's not necessarily always going to work, but I think there is going to be a lot of help and advice on that. So sort of watch this space with that and get in touch with the primary care leads about that as well, about what help there's going to be on hand for practices to try and help with the NHS app. But again, I know there's lots of issues there with the demographic, but there is some advice there, and always happy to try and help further if I can with any particular questions.
Anil?
Hi, speaking as a GP partner, not as an LMC rep today, I just think that we need to push as practices. The impact assessment needs to be done by the ICB on this big measure. It's not for practices to come back and actually give him information. We know the contract, we know the national screening programs. If the ICB wants us to support breast screening, bowel screening, cervical smear, recalls, flu, the impact it's going to have by not using text messaging is going to be huge. And I think we're very short-sighted if we think suddenly that we can just move from one platform to the other. Right now, nationally, the NHS app is about 46% uptake right now. But in the Darby report, if anyone's read the 168 pages, it's only 20% actual usage across England. So if you want to make change, yes, you can start using NHS app, but it's going to take time, weeks, months, or even years to embed it. You can't suddenly just stop over and move to one platform to the other and think patients are going to be able to have a digital phone, have an iPhone or Samsung, which has an app in it, which we know about.
Hi there, I'm calling from the outside practice surgery regarding the text message we received from your name.
Hello, sorry. So basically, I just think as practice, we need to be really mindful about just accepting this as a change, because it's going to have a huge impact on you as a practice, on your CQC, when they come and ask you about your other elements of support, of holistic care. Your GP core contract does not include bowel and cervical smear, all the other bits and pieces, but CQC does ask you those figures. What are you doing as a practice to make sure and maintain those figures for your patients? Social prescribing, when we're doing referrals, when we're doing navigation, those patients need information. Our clinicians send out information leaflets. It's all well and good saying that you're going to provide guidance. The guidance isn't very simple. We don't have a white population that live in Newham who speak English. We've got a very multicultural, mixed diversity where unfortunately a lot of them are unable to even read a text message. So you have to write the text message in a way that they can actually understand it and actually know what it's about. It's not as simple as just putting in RSV, come get your vaccine. You need to explain it a bit more. So we need to really take the demographic of our borough into consideration. So Jack, if you can take it back to the ICB, that we would expect them to do an impact assessment on this change and not simply put it through. And just lastly, for information for everybody, I attended the Now Digital IT group as a GP provider on Tuesday this week. It's very disappointing to hear that the digital team were not aware or were not consulted in this change. So Dr. Osman Bhatti and his team were not actually consulted. It's managers that have made this decision higher up in the chain. So please do take it back, and it's going to have a bigger impact than we think in the short term.
Thanks, Anil. And Jack, over to you. And then after Jack, we'll go on to the next item on the agenda.
Thank you. Listen to all of the concerns, and I appreciate them, and I will take away and feedback, and I'm sure LMC colleagues will take that message as well. Just wanted to echo what Laura had said, that the ICB are looking at what support we can give and webinars, and also sort of looking in the background about how we can potentially support, practices in a different way. So please do, take the webinars on and share that learning. I think we can sort of help alleviate some of the pressures by looking at how we're utilising text messages and just being mindful about the credits and sort of how many characters we're using, because shortening URLs and things could have a positive change and just alleviate some of those pressures. The other thing was just to note on the Liz sort of meetings and groups. So the work is the meeting, the group of GPs that are involved. It's an established group that Pat Radley had set up previously, so it's not a new one, but I will share who are invited to those, so you're aware. But it is a long list of GPs who do attend and do contribute towards those meetings. So it's not a new thing. So there might be some people on the call thinking, I used to be involved in that work, does this mean I won't be anymore? That's not the case. We're continuing the working group that was there, and we'll continue with that membership. But if that needs to be reviewed, then please do let me know and we can see what we do there. But that meeting will be next week, and papers are going out today for it.
Tammy, just quickly.
So just to say, I also put in the chat a link to the LMC template letters. Just important that if there any sort of unresourced work is coming back to us, that we are using those letters. Our secondary care colleagues are really keen for us to do that, the ones that are engaged, to help them sort of get that message about sort of what's their responsibility. So I just popped it in the chat, so just to highlight that to you. Thanks.
Thanks, Tammy, for sharing that, because I think that was one of the things that I was looking for, because I think that if we are all doing the same thing And if all of the practices are using the same letter, so when we're knocking things back to secondary care, if it's the same letter they're getting each time, it will have more of an impact. So thanks for sharing that, Tanya. Okay, and Daniel, thanks for joining us. It was good to have you with us. I'm hoping that the LMC will be joining us every month. So just to remind colleagues that if you do have any issues that I think are relevant for the LMC, you can either email your question or your query to the general NHC email address, so we can then share them before the meeting, or you can bring them to the next forum. Okay, thank you. Right, so the next item on the agenda, we've got Leanne with us, who's our lead roving team nurse at NHC. She's going to give us some clinical updates. Thanks, Leanne.
Hi everyone. Hi, I'm Leanne. So, thanks for introducing me, Dr. Apana. So yes, I'm the nurse that works for the roving team as part of NHC. So we held a few MMR clinics in July, and I've just there's some information here on this slide. So in total, we called just over, our admin team called just over 1,000 patients or parents for children who were eligible for either their first MMR vaccine or second. And we were able to book in 164 children in the month of July. 91 MMR vaccinations were given. Unfortunately, we had 73 that DNA'd. I guess the positive is that we had more children vaccinated than our DNA, than who DNA'd their appointments. 11 children were also given additional vaccinations. So the diphtheria, tetanus and polio vaccine was also given. So we attended 5 GP practices, and we also we planned to attend 4 community events within July. However, one of them got cancelled for unforeseen circumstances. The police had closed the area the night before, so we were unable to go to that particular event. However, I did go to Wood Grange Baptist Church, and I also went to a voluntary organisation, Docklands and Carpenters Food Bank, which is in Stratford. Unfortunately, no vaccinations were given at these voluntary organisations. However, there was a lot of engagement conversations. A lot of children at the Wood Grange Baptist Church, a lot of the parents that came, their children, the good news is that those children had received their first MMR vaccine, or they'd had both vaccinations, and the parents were very, they understood the need for the MMR vaccination. However, it was slightly different at the Docklands and Carpenters Food Bank, where a lot more parents that did attend the food bank were a lot more hesitant. So the first day that I attended with my colleague Amira on the 22nd of July, parents are they didn't really want to engage much with us at the beginning of the session. Towards the end of the session, they started to sort of warm up and come and have conversations with us. However, when we attended on the 24th, which was 2 days later, was able to just explain in more detail the importance of the MMR vaccination and all children's vaccinations. And we've also agreed to go back and do health checks, because a lot of the service users that attend this food bank are not registered to GP practice because of homelessness, or they're new to the country, which is something that we will help get these people registered to GP practices, or just lack of information in regards to children's immunisations and lack of understanding. So that's going to be an ongoing piece of work with that particular food bank, which is in Stratford. But overall, was able to vaccinate 91 children in July, and hopefully there'll be more MMR clinics that we're able to carry out, potentially, hopefully at the beginning of next year. Does anyone have any questions about the MMR before I move on to the plans for the roving team? Okay, so so the plans for the roving team from September for the rest of this year is we hope to start the autumn programme on the 3rd of October. So we will be attending Westgate and Mornington Care Home, the 2 large care homes within Newham, on the 3rd, 4th and 5th of October. So we plan to complete this care home between 2 to 3 days. And then on the 7th of October, we hope to carry out our first housebound list of potentially about 20 patients per list per nurse, and these patients will be offered flu and COVID vaccinations. We are receiving our list of patients who are eligible, so these patients will be contacted nearer the time and booked in from the week beginning the 7th of October. And we will provide health checks to patients that have not had a blood pressure checked in, more than a year or so, or patients that just look visibly unwell. And then I'm also going to support the employee health checks as part of NHC. So the first one is at Gillian's Reach, which will be the week commencing the 23rd of September. So that whole week I will be there with our admin and HCA staff carrying out health checks for employees who work at Gillian's Reach, which is like a shopping outlet centre in Newham. So that piece of work will happen at the end of September, and then the autumn programme will begin on the 3rd of October. And hopefully would like to complete our autumn flu and COVID vaccines by the 20th of December. And yeah, that's our aim. But if we've got a few patients to see afterwards because they were unable to get booked in before, then usually there's a few days after that we can have a few mop-up clinics. But hopefully our aim is to finish that piece of work by the 20th, and then going into the new year, children IMS clinics and cytology clinics as well, which with the focus will be from January to March. And that's the plan so far. Any questions?
No questions, Leanne, but thanks for sharing that. That was really useful. There was one request to have the contact email for the hard to reach patients, the hard to reach children. So what we will do is we'll send an email with the details out for the practices again. Tammy?
Okay.
Thanks, Apna. I'm glad that Asma's on the call. For the workplace CVD checks, I wasn't aware that we were starting quite so soon, Leanne. Have we, because I haven't seen sight of the paperwork that's going back to GP practices, and I did ask for that. I did email Jyoti. So I just wondered, have you agreed that pathway so that as practices, we know what's happening? Thanks.
Yeah, for that one, Tammy, as you are aware, because we haven't received the formal confirmation yet. So what Leanne has updated, that is the plan, what we are doing. But we are expecting the LBN is going to sign the MOU. Probably that MOU is with their legal team now. So in 1 week time, and then once we receive the confirmation, and in terms of that issue of the paperwork going back to GP practices. So right now the process is any hypertension or anything that risky patient, that will go to the pharmacy, not going back to the GP practices. That is the process we have agreed with the commissioner so far. But again, we are waiting for the final version for the commissioners.
Hi, Tammy.
Hi.
Hi, Tammy. Sorry, I haven't had a chance to reply to your email. But the reason also I haven't replied is because we're still sort of, in discussion about that. Once, we have a firm sort of, agreement, I'll definitely run it past you and get your inputs as well. Sorry for the delay.
Thank you. No, it's okay. I just, that's fine. Thank you.
There have been, so I'll tell you what, with the workplace CVD checks, we only got sight of the MOU just, I think on Wednesday. So there has been a lot of delay from DHSC side. And now we're just kind of, really in that, in the process of looking at pathways and how do we feedback. I'm also attending some of these, London-wide meetings to really understand what other local authorities are doing. So it's just something that we currently don't have an answer to, but it's work in progress, and I'll reach out to you, Tammy. Thanks so much.
Thanks, Wax.
I was just gonna. I don't know if Paul's on the call, but obviously texts don't just affect practices, they affect federation as well. So are all our patients who are COVID eligible going to be getting a text out, or what's the plan this year? Because I don't know what's kind of been decided. And then how do federations sort out texting and stuff like that?
I think Paul is here, but I'm not quite sure, to be honest with you, because Paul, are you there?
Yeah, I'm here. In terms of the texting, we don't do that. We can do that for the enhanced access appointments, but we're not doing borough-wide, texting campaigns. So that's not something we've considered for the COVID.
Okay. Paul, it might be worth us then working out how we're gonna, while we have got no limit, making use of it for one last time. Because obviously those patients, it's going to be very hard for us to get to those 10,000 patients, if you see what I mean, that we're expecting on the phone. And it's absolutely not fair on practices to pick up the phone and have to contact them as well, with everything else that's going on as well. So we need to have something at least that's a little bit more automatic. But we've got about 3 weeks, so I'm sure we can work something out. Maybe we catch up next week.
We'll catch out afterwards, Max.
Yeah.
Okay. Great. Thank you both. Right. Jyoti, there's a question for you in the chat bar. So if I can ask you to please have a look at that. And in the meantime, I'm going to move on to the next item on the agenda. So we've got Dr. Nick Jenkins with us. I hope he's joined. He is.
I'm here. Hello.
Hi, good afternoon. Thanks for joining us today. So just to let everybody know, Dr. Jenkins is a consultant at Newham in the emergency medicine department, and he's going to be talking to us about SDEC. And I think that we will try and give you plenty of time for questions after as well. Okay, so over to you.
Brilliant, thank you. Thanks for having me. As you say, I'm Nick Jenkins. I'm one of the emergency medicine consultants in Newham. Been here for a couple of years now and have recently taken over as our lead for the UTC. So I'm really hoping that we might get into a conversation about all things sort of non-ED, if you like. So the ways round the emergency department rather than having to go straight through the middle of it. So traditionally, as you all know, patients got referred or turned up to hospital, and in the olden days, which doesn't feel so long ago when you're as old as me, but people who were referred from elsewhere, either from primary care or from clinic or from endoscopy or somewhere like that, who needed admission, could go straight to a admissions area. These days, none of that is ever available, and so those patients all end up in the emergency department, and the emergency department gets clogged up, and we, in common with everybody else, are trying to find better ways of getting patients through the emergency department. And there's two ways of doing that as far as we're concerned. Firstly, you try and offload everybody who doesn't need to be in the emergency department out of the emergency department into some other pathway. And for us, those two pathways are basically same day emergency care and the urgent treatment centre. And that gives you only the people who really need to be in the emergency department there, and hopefully then gives them a better experience through the flow. Part of what I wanted to mention was the fact that we are merging our emergency and medical ambulatory. So SDEC will, from the 30th of September, be one big space near to where it is now, but not exactly where it is now, and we'll have emergency medicine and acute medicine essentially co-located and working from the same pool of patients, because there are quite a lot of patients who could be seen in either place. If you are a 30-year-old woman with chest pain, then it doesn't really matter whether it's somebody from the emergency department or somebody from ambulatory medicine who sees you. So I didn't really want to say a lot more. I'd rather hear what you think. I'd like to try and answer any questions you've got, but I'd also really like to know what it is we need to do differently and better to make the process easier for you to navigate and better for your patients, really.
Thanks, Dr. Jenkins. I have one thing, so I'll start off. So practices have been doing an exercise where we're looking at our A&E attendances. The idea was that we review any discharge summaries, any A&E letters, and in that piece of work, so just to put it into context, I have about 3,000 patients, and in the first quarter of this year, according to the search that was run on my system, I had about just under 100 patients attending A&E 3 or more times, which was not correct. The issue was that I was coding every single A&E letter that was coming through as an A&E report, and then I was adding another code saying seen in accident emergency department, so they accumulated. But one of the things that it did highlight for me is that we have, so if there's one patient that goes to A&E once, we'd receive on occasion 2 or 3, sometimes 4 A&E letters into our system. So if we accumulate that in terms of the amount of time, so that's, let's say 3 or 4 minutes of somebody looking at each letter or somebody coding it. And sometimes the letters are written on behalf of somebody else, and then the person who had seen the patient actually writes another letter. So it's almost like it will be one letter but different variants of it. Or sometimes it will just be when they're checked in, there's a discharge letter sent to the GP. So I do have examples, but I think that this might be something that's a quick fix that somebody hopefully should be able to look at.
I love your optimism. I don't think it is a quick fix. I hope we're getting better. So we're conscious of this as well. Every time a patient is discharged, a letter comes to you. And the trouble is that, for example, when we move somebody from the emergency department to SDEC, that involves a discharge. What we're trying to do now, so we can't stop that letter coming, but what we are trying is there should be no clinical information in it. So it should be obviously the dud letter. It just will say ED appointment booked. And that's if we send a patient, for example, to SDEC or to EGU with early pregnancy bleeding, or to ambulatory medicine. All of those places, because they aren't the emergency department, get the patient discharged from the emergency department, and that makes a letter. You then get another letter when they are discharged from wherever they go next, unless they get admitted, in which case you get a letter telling you they've been admitted, and then you get one when they're eventually discharged. So I do understand there are a lot of letters. I'm sorry, I don't think we can reduce the number. We are trying to stop the story you give where they are the same sort of story but not exactly the same. That shouldn't be happening, and I'd be interested in examples of that from now. Historically, we're well aware it did happen, but we're trying to lessen that.
Okay, thank you. So I will share some, I will find some patient examples to share with you with regards to what I was referring to, if that's all right.
Yeah, brilliant. Especially sort of from now forwards, because it has been I don't need examples of how it was a problem, because I know it was. But if we aren't getting it any better, it would be great to hear how we're not getting it better.
Okay, thanks. Laura?
Hi there. Yeah, it's a similar thing about letters. It's a conversation that I was having with some A&E consultants about 6 years ago on emails. I have to dig them out. About the letters that are often coded as new diagnoses and they're not. For example, a DVT or a PE, when actually it was a working differential. And they go to our summarizers and they can get coded, and it's wrong clinical information, and it's happening a lot, and it's happening all the time. And I pointed out as a clinical, clinical incidents really. And I was told that there was going to be some work done in the next couple of years about the A&E letters, about how the format was going to change. I haven't seen that it's changed, and I didn't know whether that is something that is happening, or can a new working group be made for this, because this is obviously our PANA's examples are an issue. in terms of duplication, but this is actually clinical information that's wrong on the A&E letters. So can we look at this or have an update with what's happening with this, please? Thank you.
Thanks, Laura. Yes, of course. I don't know anything about that. So if you, I'm sorry, I don't know who you were talking to before. If you can remember and they're still here, I'll talk to them again. I'll talk to them rather on your behalf, or we'll start again. Without seeing some examples, I could only guess at what's going wrong, but obviously it shouldn't be happening. So yeah, let's try and stop it. It's a bit worrying.
Okay, I'll get in touch. Thank you.
James?
Hi, it's just a question really on what the if the pathways are changing for referral in. So, for instance, if we see someone in the practice who I don't know has chest pain or something that needs an urgent assessment, what is your preferred way of us furnishing these people, other than just telling them to pitch up to A&E with a letter that we've written? Because the reality is, trying to call up a registrar to let someone know that they're coming in, often that takes 20, 30, 40 minutes, which you can't do in the middle of a busy clinic.
Yeah, I completely agree, James. Thank you for bringing that up. So we don't need you to talk to anybody unless you particularly want to. And then, of course, we're happy to talk to you. I'm sure the registrars would be happy to talk to you if you could get hold of them, but I agree, they're not always easy to get hold of. So please, what we would like is the patient to come with some kind of evidence of a primary care consultation. So it doesn't have to be a whole letter like you're doing a referral in history, just I've seen the summary of your consultation is brilliant. Why are you sending them? What are you sending them for? And I would really love it if you would say who you think they should be seen by, because that really helps us. So if they arrive with, we had a 12-year-old girl this week with really dramatic menorrhagia and a hemoglobin of 70, who arrived with a letter that was clear that the GP who'd seen her thought she should be seen by the gynecologists, which is really helpful, because when the gynecologists say, well, this is obviously pediatrics, we are able to say, no, hang on, they've been seen by a primary care expert who says this is for gynecology, please come and see them. And it just makes the whole journey so much smoother if we get somebody with that letter, and we don't mind. So if you send that via Accurex, if you've only had a telephone consultation with them, that's all right as well. Just something that the patient can show us that says they've had a primary care consultation that has led to this attendance. And we will either direct them where you think they should go, or if, James, like your example of chest pain, we'll direct them to SDEC, where somebody with the right skill set will see them.
Brilliant, thanks.
Any other questions for Dr. Jenkins?
Hi, Aparna. I just put one in the chat. It was just regarding Dr. Jenkins. I think that's really refreshing to hear that you're happy to not receive phone calls. And you also accept that we as GPs are specialists in our area. We can diagnose and hopefully give you some indication of where the patient should go. Only last week we had a queried urological testicle torsion, and the registrar refused to see the patient. It said, no, it has to go to A&E. Then he went to SDEC. SDEC said, no, it needs to go back to A&E. Urologist still refused, and if A&E assess the patient. So hearing this from yourself is just wonderful news that you won't have these issues that we have as well. Just regarding if there's any guidance you can give us primary care colleagues regarding low hemoglobin. As a general rule, if it's less than 8.0, we send it to A&E. Is there any new kind of evidence or any kind of guidance as a local hospital you can give? Because I know different hospitals give transfusions, some don't, some assess, some don't. So we send in quite a few to you. Some get a transfusion, some come back with different messages from different consultants and different teams. So just that we could standardise it across Newham with our local hospital.
So these are ideal SDEC patients, particularly if they're not dramatically symptomatic. It's difficult, isn't it? If the old boy turns up with his chest pain, it turns out his hemoglobin's 45, then of course he comes to us. But there's an ambulatory process for all of this. So the menorrhagia and the gynae ones should be going to the gynae assessment unit, and that shouldn't need to be via us. But if you can't do it any other way, I'm really in the business of trying to get the blocks out the way, like that urology patient and the boy or man with his testicular pain. That's exactly what we're trying to unblock. We don't always succeed either, but we're working hard at it. And if you guys, I don't want to waste your time on anything you don't have to have your time wasted on. And I can't help sending you a letter every time somebody moves around the hospital. There's just no way around it. But I know that wastes your time, and I can't do anything about it. But I don't need you to phone up if you know what's going on, unless you want. If there's something in particular that you want to convey that you don't want to put in the letter, or if there's something that you want to ask to see whether they really need to come or don't need to come, then ring one of us. But otherwise, please don't. So the low hemoglobins, I would send them to an SDEC pathway. So again, ask them to come early in the morning, so that we've got all day to sort them out. So even if you see them at 4 in the afternoon and you think they're all right to come tomorrow, send the poor patient tomorrow, because if they come at 6 o'clock at night, by the time they get to us, they're going to go through a miserable evening and probably still get told to come back, because we would almost never transfuse those people overnight even if they needed a transfusion, because it's dangerous. So we would do that in the day. I don't know how the medical crystal ball decides who gets an iron infusion and who gets a transfusion, but SDEC will work that out. So the acute medics presumably have a plan. I don't know what it is, but SDEC is exactly where those people should be, unless you're really worried about them. So again, send them with a letter or an Accurex message that says this patient's for SDEC for assessment of their symptomatic anemia. If they're not symptomatic, I'm not sure they need to come even to SDEC. But if they've got some kind of symptom, which presumably they have, otherwise how would we ever have discovered they had a hemoglobin of 80? But we're happy to see them, and if you want a discussion, we're happy to discuss.
Thank you. And is your SDEC open 24 hours, or is it limited still from 9 till 8?
No, so there is SDEC 24 hours. The acute medics are only 9 till 5 at the moment, but we're looking at trying to persuade them to work slightly more. But there is the SDEC process operates 24 hours a day, but it definitely operates better during the day, during the week, because it has more consultant input in. So we always have a consultant from the emergency department and a consultant from acute medicine there all day, all on a weekday. At the weekend, although we have 2 consultants in the emergency department, SDEC and CDU are part of what they do, but they're not dedicated solely to that at the weekend.
So, Dr. Jenkins, I have one question, and apologies if this has been shared and I just haven't had sight of it. What would be useful is having some sort of poster or a flow chart or something that details the service and how we can refer, because in this meeting there's just a small proportion of our workforce. So I found something that I've just put in the chat bar, but this is from 2021. So I think it's probably the numbers and things are probably not quite correct. But if we could have something like this that we can share within our practices, that would be most useful.
Yes, I'm just looking. Absolutely, sorry, I'm just looking at the thing you've put in the chat bar, which I'm sure will need updating. Does need updating. Leave that with me. Where would be the best place to send it? I'm sorry that I'm new to Newham, so I'm still struggling to know quite who's who and what's what and how the best way to disseminate this sort of stuff is.
So usually if you send it to Maggie, who may have been liaising with you about today's meeting, So if you send it to Maggie, what we can do is we can make sure that it goes into the generic practice accounts, practice email accounts, but we can also get it to GPs and other colleagues that this would be useful for. So basically, we'll distribute it if you send it to Maggie.
I'll send it to Maggie. Give me a week or two to make sure we've got. It'll have to, like everything in this organisation now, it has to go through a committee process to make sure we're all agreed with what we're saying. But give me a little while, and I'll send something to Maggie.
Okay, no problem. And then just one other request from you. So we really appreciate you taking the time, because I think one of the things that all of us are looking to do is build relations between primary and secondary care. So it was really good to have you on this meeting with us. Are you happy for colleagues to contact you if they have any query that you're able to help with? And if you are you happy to share your email address or your
Yes, so
how best to contact you? Sorry to put you on the spot.
No, I really am, and I don't know. I don't know how much. I've just put my email address in there. You're welcome to email me. If you all email me twice a day, I probably won't be able to cope, but I will be very happy to try and respond. So the reason I've taken on the urgent treatment centre lead role is because I want to improve the relationships between primary and secondary care as well. So I feel like we're all after the same thing, and if we can just remove the unnecessary obstacles, then I feel like things can only get better, and there is quite a lot of room for improvement, I think, and so that always makes it exciting because we won't have to do much to make everybody feel a little bit better. So yes, I'm really happy to try.
Okay, brilliant. Thank you. And just one more question.
And I'm happy to come back here if you want me here again in X number of months. I'm really happy to come back here and see whether there's anything else to talk about. I don't, again, I'm not trying to duplicate. I know there are other meetings that other people have that are already set up, and I don't want to interfere with things that are already in existence. But if I'm useful to you, I'm happy to come and listen.
Oh, brilliant. That's fantastic. Just before we let you go, we've got one more question from Laura.
I'm so sorry, just very quickly, and I can't believe I forgot to ask this before. So Dr. Jenkins, I don't know if there's any work being done from any of the service alerts about, for example, bit notes in A&E or GP, can you repeat this Udinese in 1 week type things. I don't know whether that's getting a review in terms of what should be done from A&E and what is reasonable to pass back to general practice, because there have been so many examples of that. Because obviously I do know that A&E can't follow up everything when it's reasonable for GP, absolutely, but there's some things that really shouldn't be followed up by us, and it's not practical. So I just wondered if there is work being done there.
So there really is. Laura, you broke up a little bit, so I don't know if I'm exactly understood the question, but I think it's about, are we asking you to do stuff that is our job rather than your job in the follow-up space, and how do we decide whose is which person's job? Is that what it was about? Anybody?
Yes, that's right. That's right.
Yeah. So yes, and I know we get this wrong sometimes, and it's amazing, isn't it? People have a phenomenally short memory when you're asking them to do something, and a phenomenally long memory when you're giving them permission not to do something. And so the fact that somebody once 20 years ago said that you couldn't do anything without GP fund holders saying that it was legit is something that people cling on to as an excuse for not doing our own work, and it drives me up the wall. So again, I'm happy for you to show those to me. I saw a GP alert yesterday that was basically, I've had two in the last week, one asking the GP to refer a patient to the rapid access chest pain clinic, and there was no need for that. We should have done it, could have done it, and didn't do it, and we should have done. The doctor who made the mistake was new and didn't, it was our fault. He didn't understand that he could. He thought all he could do was send them back to the GP, so he now understands, and we've added it to our induction process. So we are trying. I think you're right, aren't that there are some things like that are obviously our job. There are some things that are obviously not, and then there's a load of grey stuff in the middle. And again, if we're getting it wrong, I'm happy to hear.
Brilliant. Thank you. Thanks so much, Dr. Jenkins. I'm sure we'll all be in touch.
Fit notes and FP10s has gone in the chat. I don't know. Fit notes, I hope we do when we should. And again, if we don't, let me know. FP10s are a nightmare, but I am just about to join a program that our trust is running to see about electronic FP10s to community pharmacy, which I'm very excited about because we have a lot of trouble getting TTOs done properly. And I don't know whether that is what the FP10s question was about.
I think it was alluding to the patients being discharged from A&E and the GP being asked to provide fit notes, FP10s, and James has put yes, it was. Yeah,
so we shouldn't be doing either of those things. I mean, it's if we give them a first fit note and say, you know, if you're not, we think you'd be better in a fortnight, but if you're not, you'll need to go and see somebody else. I think it's probably better for them, I think, to come and see you rather than come back and see us then. But the first one should definitely come from us, and it should be for a realistic length of time. If you put a bus driver into a below knee plaster, you should give him a 6-week fit note. You shouldn't give him a fortnight and tell him to go and see his GP if he wants another one. That sort of thing. FP10s, I'm sorry if we're ever asking you to do FP10s. I can't think why we should. We should be asking people to come back to the hospital pharmacy if they need something that we haven't got a supply of. So yeah, again, I agree with you that that shouldn't happen. I don't promise I can stop all these things overnight, but I will try. And examples are helpful to try and let me target if it's a particular educational thing that we haven't done, or if it's a particular group of people who are repeat offenders, or whatever it is.
Okay, great. One more question for you.
I've just seen Laura's question. That was my dad. Yes, my dad's a GP, so he's now a retired GP. But I do have some sympathy with primary care, maybe.
Good. Right, it has actually been really fantastic having you here. We will share examples with you, and going forward, I think that we should be able to improve the situation for the patients and for us in primary care as well when it comes to patients needing emergency care. So thank you.
That's right. You're welcome. Nice to meet you, sort of.
Okay, take care. Bye-bye. Right, so we've got Emma. I think Emma should be online.
I'm here.
Hi, Emma. Sorry, we've overrun a little bit, but I think you still should have plenty of time.
Not at all. It was great to hear that segment. It was so lovely.
Okay, good. So
we won't take it.
I'm sure everybody knows who Emma is. Emma's our GP clinical lead for babies and young children, children and young people. And I think, have we got Ellie here as well?
Yeah, I'm here as well. Hi.
Hi, Ellie. Thanks for joining us today. So the two of you, I understand, are going to be talking about the Vulnerable Children's MDT and how we are hopefully going to be implementing it within our practices. So over to both of you.
Yeah, thank you. Do you want me to give a run through, Emma? Yeah, I'm here for questions or anything, and I'll pitch in with my bits at the end. Lovely, perfect, thank you. I'll just introduce myself quickly. So I'm Ellie, I'm a programme manager in the ICB based within Newham and Children's Health. So as we just said, this is a new spec that's going to be launching this month around vulnerable children's MDT working. I know we haven't got long, so I'll give a quick overview of the purpose of it and what's required in the spec, reporting and payment, and then Emma and I are happy to take any questions at the end. Thanks for the slides, Maggie. So just on this slide, the spec kind of centres around regular meetings between health visiting and primary care. So we're saying monthly, but that is kind of open as long as they're regular. It is going to launch later this month. So it should have been circulated to all practices at the beginning of August for an 8-week lead time with some info. It is based on the MDT link meetings guidance, which I think many of you will be familiar with. So hopefully this won't be entirely new. The payment comes from existing outcome measures, that infant feeding and childhood appointments, and that covers kind of regular meetings with each practice, and also the reporting as well. I'll go through the payment structure a little bit later. Just in terms of the aims, the kind of reason behind this, I know many practices probably already do this and meet regularly with their health visitors and have really good communication But the idea is to get more of a level playing field across Newham.
And then I called.
Oh, sorry. So to give practices some funding to really ring fence some time to meet with their health visitors and do some of the work that is associated with this, and to kind of build those relationships and just give some protected time to actually kind of review these notes and kind of attend to cases outside of consultations with families themselves. So if you could just go on to the next slide, please, Maggie. So in terms of the scope, because it's health visiting, it's children aged 0 to 5. We've pitched this at those families that are more early help level, so less likely to meet threshold for statutory services, just considering that those that do meet threshold are likely to already have kind of core groups or other meetings or forums around them. So this is aimed at those families where there are concerns or points to address, but they're perhaps unlikely to meet kind of criteria or threshold for other services. It's also a chance to check in between agencies around information requests that have been made to primary care or where requests have been made to social services. So that kind of feedback both ways. And then again, any cases either health visiting or primary care have concerns about and would like to cover. And then we've also put a point, not all children on child protection, but just those that are for primarily medical reasons. Within the full spec, it does kind of give a suggested rolling programme of how these cases can be covered so that they can all kind of be run through in a 3-month cycle. On the right-hand side of half of the slide, so we've suggested roles that can attend this meeting. It's open to practices. We know that practices are structured differently and have slightly different roles. So those roles are suggestions and practices can flex that according to how people work with families and what roles are best placed to attend. Thanks, Maggie. Can you just go on to the next slide, please? Again, this is in the spec. I won't go through it in detail, but it's just a sample agenda to help support with structuring your meetings to kind of make sure that you cover all the requests that are made to primary care, to social care, and then those kind of early help level cases as well. That's open to be adapted and used as you wish. Next slide, please. So I'll go into the payment. I apologise, I know this slide probably looks quite confusing. What we've done is work closely with the LIS working group to try and devise a payment structure that is fair. We recognise that some cases, particularly where there's safeguarding concerns, it's difficult to predict the workload involved. So what we've aimed to do here is make payment for meetings and reportings that is kind of structured according to practice size and deprivation to hopefully provide more funding for those practices that are more likely to have a higher caseload that will need discussing at these meetings. So that's why it looks quite complicated, but I'll go through it briefly because it's kind of split into the 3 parts. So the first payment is for each meeting. We've said 12 meetings per year with the suggestion that that's monthly, but again, that's open to flex. And then for each meeting, practices will receive a payment based on their list size for 0 to 5 years. And so those with the smaller list sizes will receive a lower payment, and then the larger list sizes will receive more. So that payment per meeting is between £200 and £440, and that's made per meeting up to 12 meetings per year. This is all provided in the spec, so the details are kind of laid out completely. Then there's an annual report payment, which is standard across all practices. So that will be paid at £1,200 per report once that's received. And then third is a new deprivation payment, which reflects that those practices in the most deprived areas are more likely to have complex safeguarding cases. So we've taken the deprivation decile for all practices in Newham, and then those in the second and third most deprived will receive a payment. And again, that's split according to list size. Within the second and third decile, there'll be a payment, and then those with smaller list sizes will get a payment and larger list sizes will get a larger payment. So I won't run through all the values here, but again, that's in the spec, and that will be calculated and paid to each practice. So payment is on a practice level. My understanding is for this year, because it's coming in partway through the year, practices will get their kind of monthly payment as usual, and then the end of the year it will be reconciled. but going forward, it'll be 50% upfront at the beginning of the financial year and 50% at the end. There's a few notes as well. So I think we heard a lot of clear feedback that attendance at meetings from other agencies is challenging to manage. So we do ask that every effort is made to liaise with health visiting and other parties, but if for some reason another agency is not able to join, then practices will still receive payment, providing they confirm that a meeting was held and did go ahead. Meetings can be virtual or in person, whichever works, but they do need to take place rather than an email discussion. And there's just a list there of the payment is intended to kind of contribute towards attending the meeting and the admin and coding afterwards. Just go on to the next slide, please, Maggie. Thank you. In terms of reporting, we've kept it really simple. It's not intended to be onerous, so it's a single annual return to verify the number of meetings that took place and capture whether the health visitor attended. The idea of that, so this has been developed with health visiting and they're fully on board with this spec, but at the same time, we recognise that they're in a service review and will have staffing challenges themselves. So this is just to capture the info so that we can identify any practices that are struggling with engagement from health visiting and pick that up with the service directly to support them. So it's not intended to be really onerous, and this is the extent of what needs to be completed. Final slide, please. As a final slide on data protection, so again, there was a lot of feedback in developing this about the coding in records now that patients can request access to their records. So there is a section and guidance within the spec on how to manage that. So we do ask that practices read that, and if they've got any questions, pick that up before they go live with this. So I'll pause there. That was kind of a whistle-stop tour. Emma, if you want to add anything, otherwise happy to take any questions. Yeah, a few things if that's okay, Ellie. Just to say, really, this is based on really well-recognised national guidance. We know that these meetings do actually have quite a big impact on vulnerable families. There is a lot of evidence to support GPs and health visitors working together in this space. The additional context that we can provide each other in these, especially the sub-threshold families, which are always the families that have made me quite nervous. I think it's also really useful given that our staff, you know, our staffing levels are higher. There's more people working part-time, to have a clinic slot, a rolling clinic slot, where if, you know, when you're coding something and you notice that a child wasn't brought or, you know, that kind of thing, that can be put on the clinic list to be discussed. So there is a central area where things that are coming up for clinicians, where that case can go and can be discussed. And yeah, it has been, you know, when we look through the notes of cases where things have gone wrong, not because of primary care, just in general, where children have come to harm, then this is one of the things that we are looking at, and what was the communication like. So I'm really keen. I think, you know, part of this is about trying to funnel some money into primary care that represents a small, I know it's not going to represent all the time that you spend doing safeguarding, but to try and you know, that there is some funding towards this. The LIS, if just to check that you're signed up for the LIS for the reports that you're writing, you know, £90,000 came to Newham GPs for that. So it's another arm about trying to give you some financial remuneration for the enormous amount of work that we know that you're doing. So yeah, I think that's it from me. But as ever, if there are any specific questions here or later, then just do let me know.
Thank you both. Do you have any questions? No, okay. I think it's because that was very informative. Okay, we've got just give me 1 second. So Dr. Sheetal Shah's asking that if that often there's older children that are on a plan or on safeguarding alerts raised by other agencies, and only the health visitor can update the surgery from their RIO records. So are we able to discuss these cases in our MDT?
You can do, I mean, it's really up to you who you can discuss, and if your health visitor's happy to feed that back, and most of the health visitors are happy to pass on information that they have, and quite a lot of these families do have one, you know, they often have a sibling who's under 5, but you know, they are a great resource, and we know that it's tricky, especially for the child in need space, about finding out information. So, you know, anything that we can do to promote better working relationships between health visitors and GPs is really important. And I think, you know, the person that's doing the most of the safeguarding work or the baby check, really, you know, so you're not doubling down on work. It's about highlighting the most appropriate people to attend those meetings. If you've got a safeguarding administrator, to feed that in, because ideally it should be, you know, when you're discussing these families, it should be referenced across the siblings notes, so that everyone, so when a GP is looking in the family records, they can see that they've been discussed. But that is all in the spec, and I will be talking about it again at Safeguarding Leads meeting, and we have level 3 training coming out on the 18th of October that's just about to be circulated. So there'll be, you'll hear more about this from me anyway, but yeah, we're excited to be offering some funding for this.
Thanks, Emma. I think the email with regards to the training was circulated yesterday. Right, do we have any other questions? No? Okay, good. Right, so that was everything on our agenda for today. Was there any other business or anything that anybody wanted to discuss or raise or speak about while we're all together? No? Okay, good. Right, so I hope everybody has a lovely weekend. Just a reminder again with regards to the RSV vaccines. I know that we're all thinking about, and we all tend to prioritise the flu, but I think we do need to start administering the RSV vaccines if we haven't already done that. I hope everybody has a good afternoon and a good weekend, and our next forum will be in 4 weeks' time. Okay, thanks everybody.
Thanks, bye.
Bye-bye.